Hello and welcome everybody to tonight's EEC talk on the hypoparathyroidism. We're having two sessions on hypoparathyroidism, physiology, diagnostic and treatment option. Please ask your questions throughout using the Q&A button, and this session is being recorded and it will be available on the EEC website in about 2-3 weeks time. We have two fantastic speakers today, Lars Rejnmark from Denmark and Ottilia Buch from UK. The first session will be around 45 minutes, with the second session being 30 minutes. Just wanted to update you on the endocrine nurse survey, which is closing on the 16th of November 2025. So if you want to shape the future of endocrine nursing, please fill the survey, and you will have a QR code at the end of the presentation. I now want to introduce our first speaker. I have Professor Lars Rejnmark from Aarhus University. He is a consultant at the Department of Endocrinology and Internal Medicine at Aarhus University Hospital in Denmark. He has contributed to many studies on hypoparathyroidism and most recently participated in updating the European Society guidelines on chronic hypoparathyroidism. Welcome, Professor Rejnmark.
Yes, thank you. And
thank you for giving us a fantastic talk on hypoparathyroidism.
Yes, thank you for this kind introduction and for inviting me to give this presentation on hypoparathyroidism. These are my disclosures. And my agenda for today is to talk about the diagnosis of hypoparathyroidism, conventional treatment, complications to the disease, and new therapies. And my presentation is based on the new updated guidelines from European Society of Endocrinology. They have not been published yet. Hopefully they'll soon be published, but there might be slight changes until they are published, but they are close to being finalized. Hypoparathyroidism is defined as hypocalcemia with low or inappropriately low normal PTH levels. It's a rare disease. There have been different studies estimating the prevalence to be between 6.5 to 38 per 100,000 inhabitants. And this means that maybe there are 200,000 patients in Europe, 120,000 in the EU, who are suffering from hypoparathyroidism. So although being rare, there are quite a few patients who actually have this disease. Normally, hypoparathyroidism is divided into post-surgical or non-surgical hypoparathyroidism. Most cases are due to surgery. Most often, total thyroidectomy is the cause of hypoparathyroidism. Non-surgical causes include genetic variants, autoimmune diseases, low magnesium levels, infiltration into the parathyroid glands, etc. And if it's a non-surgical hypoparathyroidism, it may be isolated or part of a syndrome. For example, DiGeorge syndrome is sometimes associated with hypoparathyroidism. It is called chronic if it lasts for more than 12 months. In the updated guidelines, we did a survey trying to identify all patients who have been reported in papers having thyroid surgery. And we identified that actually 1/3 of the patients who have had thyroid surgery develops hypoparathyroidism immediately after surgery. However, most recovers after surgery with about uh, uh, 33% having of those with immediate hypoparathyroidism after surgery, 33.9% recovers within the first 6 months, and further 7.5% recovers after the next 6 months, meaning that we defined hypoparathyroidism, chronic hypoparathyroidism, if it lasts for more than 12 months. And overall, it seemed that 6.3% acquire chronic hypoparathyroidism after, after thyroid surgery. But we have to remember that it's never too late. Several papers have been published on patients who regain their parathyroid function several years after surgery. So we should never give up. There is an option that you may regain your parathyroid function also after several years with hypoparathyroidism. The physiology of PTH is that PTH is a calcium mobilizing hormone. If plasma calcium levels are low in the blood, it stimulates the secretion of parathyroid hormone from the parathyroid glands. And parathyroid hormone affects the bone. It increases bone resorption, which causes bone to, or which causes calcium to be released into the blood, thereby higher blood calcium levels. PTH also affects the kidney. It increases the calcium reabsorption from the renal tubules, and it increases phosphate excretion into the urine. Furthermore, it increases synthesis of active vitamin D in the kidney, and active vitamin D in the small intestine increases calcium absorption, thereby increasing plasma calcium levels. However, if you have hypoparathyroidism, low plasma calcium levels are not able to stimulate secretion of PTH, and therefore bone are not stimulated, bone resorption is not increased. On the other hand, if bone resorption is not increased, you will end up having rather high bone mineral density. In the kidney, calcium reabsorption from the renal tubules is not increased, so you'll end up excreting large amount of calcium into the urine, having hypercalciuria, and you will not have an increased excretion of phosphorus into the urine. So patients with hypoparathyroidism, they have relatively high plasma phosphate levels. And without PTH, you're not able to synthesize active vitamin D, so you will not have an increased absorption of calcium from the intestine. So you will end up having low plasma calcium levels if you have hypoparathyroidism. The mainstay of conventional therapy is calcium supplements with activated vitamin D analogs. We most often use either alpha-calcidol or calcitriol, and by this treatment, plasma calcium levels are normalized. The goal of conventional therapy is to achieve plasma calcium levels low in the reference interval, being without symptoms. And the reason that we aim at calcium levels low in the reference range is to avoid hypercalciuria. which is common in patients with hypoparathyroidism. Two different approaches are used when titrating the treatment. At some institution, a high dose of calcium supplements is combined with a relatively low dose of active vitamin D, while at other institutions they use a low dose of calcium supplements with a relatively high dose of active vitamin D. If you ask me, this is the best approach to use a relatively low dose of calcium supplements with a higher dose of active vitamin D. And the reason for that is that PTH is not the only hormone missing. Patients also have low levels of active vitamin D. In reality, hypoparathyroidism is a two hormone deficiency state. And lack of active vitamin D should not be compensated for by using very high doses of calcium supplements. Very high doses of calcium supplements may cause adverse effects. It's often associated with gastrointestinal discomfort, obstipation, and that kind of stuff. It may cause hypercalciuria, which increases the risk of renal calcification, as well as high doses of calcium is associated with a high pill burden. In the updated guidelines, we recommend assuring an adequate intake of calcium in the range of 800 to 1000 milligram per day. And we suggest that calcium supplements is only needed if calcium levels in the target range cannot be achieved by treatment with activated vitamin D in combination with an adequate dietary calcium intake. And if calcium supplements are needed, they should be divided into several doses if the total dose is above 500 milligram per day, because amounts above 500 milligram per dose are probably not absorbed in the intestine. But hypoparathyroidism is a complicated disease. It's more than just normalizing plasma calcium levels by supplying active vitamin D and calcium. Despite near normal plasma calcium levels, patients they often have fluctuations in their calcium levels, and these fluctuations are often unpredictable. Patients have other biochemical disturbances, including hyperphosphatemia and hypercalciuria. They have a high pill burden associated with the treatment. They often have an impaired quality of life, as well as an increased risk of several complications. This is a study performed about 10 years ago, one of the first study revealing complications to hypoparathyroidism. This study did not show an increased mortality in patients with hypoparathyroidism. There have been some subsequent studies which actually suggest that mortality is increased in hypoparathyroidism. I believe that all studies performed so far have shown that the patients they have an increased risk of renal insufficiency as well as an increased risk of nephrolithiasis. Ischemic heart diseases may be increased. Patients have increased risk of seizures. They often have cataract, at least if they are non-surgical, and post-surgical as well as non-surgical patients. They have an increased risk of neuropsychiatric diseases as well as infections. Most recently in 2025, additional papers have been published on risk of complications in hypoparathyroidism. There's been a Swedish as well as a German study showing increased risk of cardiovascular diseases in patients with chronic hypoparathyroidism, both surgical and non-surgical patients. And the Swedish survey also showed an increased risk of vertebral fractures, while the risk of femoral fractures were reduced in patients with hypoparathyroidism. Further studies are ongoing on why the risk of vertebral fractures may be increased in these patients. Several studies have shown an impaired quality of life in patients with hypoparathyroidism. A study from Germany, including 264 patients with hypoparathyroidism, assessed quality of life in the patient using online questionnaires. And this study showed that compared to the general population, hypoparathyroidism was associated with significant worse cognitive and emotional functioning, including loss of vitality, pains and cramps, and numbness and tickling sensations. And this study suggested that females, they have an increased symptom burden compared to males, although there's no real good explanation why females should have more symptoms than males. Muscle function and muscle strains is apparently also affected in hypoparathyroidism. In a study, patients who following surgery had acquired both hypoparathyroidism and hypothyroidism were compared to patients who following surgery had acquired only hypothyroidism, and both groups of patients were compared to controls. The study showed that the timed up and go test, which is a test in which a patient is asked to rise from a chair, walk a few meters, and return to the chair sitting down on the chair. The study showed that patients who have acquired hypothyroidism as well as hypoparathyroidism, they spend longer time on performing this test compared to patients who only have acquired hypothyroidism following surgery. And patients with hypoparathyroidism spend also longer time performing the test compared to the controls. The study also studied the repeated chair stand test, which is a test where you 10 times are asked to raise from a chair and sit down on the chair again, and then the time you spend on raising and sitting on the chairs 10 times is measured. And the study showed that patients with hypoparathyroidism, they spend longer time on performing this repeated chair stand test than patients with only hypothyroidism and compared to the controls. In the study, knee extension strains were also measured, and the study showed that patients with hypoparathyroidism, they have a lower extension strains over the knees compared to patients with hypothyroidism and the controls. Once again, suggesting that hypoparathyroidism is associated with a decrease in muscle function. So why not treat hypoparathyroidism by supplying the missing hormone, PTH? Several studies have tried to treat patients with PTH, but until now we have not had a real good treatment of hypoparathyroidism with PTH. But now pyrrolopectin, which has a trade name Yorvipath, has been approved for the treatment of hypoparathyroidism. In the revised guideline, we recommend PTH replacement therapy in patients who continue to have signs and symptoms of hypoparathyroidism despite optimized treatment with activated vitamin D and an adequate calcium intake. We suggest to consider treatment with Yorvipath in patients with optimized conventional treatment, but despite optimized conventional treatment, continue to have frequent fluctuations in their calcium levels or symptomatic hypocalcemia in patients with impaired quality of life attributable to hypoparathyroidism, in patients with reduced kidney function or hypercalciuria or hyperphosphatemia. Yorvipath, which previously was called TransCon PTH, is a prodrug of PTH 134 administered once daily subcutaneously, and it provides active PTH within the physiological range for 24 hours a day. It is actually PTH 134 bound to a carrier protein via a linker, and when it's injected subcutaneously under the influence of physiological pH and skin temperature, active PTH is released from being bound to the carrier molecule, and then free PTH can go to its receptor, to the PTH receptors in the body, and function as PTH is still present in the circulation. Several studies have been published on the effect of treatment of patients with hypoparathyroidism with Yorvipath. Most importantly, a phase 2 and a phase 3 trial have been published showing beneficial effects of this treatment in patients with hypoparathyroidism. In response to treatment with Yorvipath, 93% of the patients achieved independence from therapeutic doses of calcium. 98% of the patients achieved independence from treatment with active vitamin D, and they did so while maintaining normal plasma calcium levels. Treatment also reduced 24-hour renal calcium excretion, causing that patients with hypoparathyroidism no longer have hypercalciuria. And in terms of quality of life, treatment was shown to improve the well-being of the patients as assessed by the SF36 questionnaire. As you can see on this figure, in using SF36 questionnaire, a higher score is better. And in response to treatment with Yorvipath, SF36 score increased while it stayed low below the normal range in patients who were on conventional therapy. The questionnaire also used a specific questionnaire on a patient called the Hypoparathyroidism Patients Experiences Scale. Using this scale, a lower score is better than a high score. And as you can see here, in response to treatment, the physical domain score improved in response to treatment. Cognitive domain score improved in response to treatment, as well as physical functioning and daily life domain scores improved in response to treatment. In the phase 3 trial, most patients were treated with active Yorvipath, while 1/3 of the patients for the first 26 weeks were treated with placebo. After the randomized period, all patients were treated with Yorvipath. And after being switched from placebo to Yorvipath, the patients initially treated with placebo, they improved their quality of life in response to starting the treatment with TransCon PTH. And similarly, the hypoparathyroidism experience scale improved in response to patient being shifted to treatment with active medicine, and it was apparently a sustained effect when they continued this treatment. Treatment also affected bones, as shown on this figure. In response to treatment with Yorvipath, bone turnover markers increased, suggesting an increased bone turnover in response to this treatment. As you know, bone turnover is normally very low in patients with hypoparathyroidism. So in reality, bone turnover increased in response to the treatment. However, when bone turnover increase, bone mineral density often decrease, which was also seen in this study. There was a decrease in bone turnover, but it was not a marked decrease. I would say that bone mineral density normalized. It was not very high any longer after patients have started this treatment. Treatment also affected kidney function, as you can see on this figure. In response to treatment with Yorvipath, the dark blue line here, kidney function as measured by eGFR improved, while those patients initially treated with placebo had this improvement in kidney function as measured by eGFR after being switched to the active treatment. The study also divided patients into those who at baseline had an impaired kidney function defined as an eGFR below 60 mils per minute, and those who initially had an eGFR above 60 mils per minute. And as shown on these figures, kidney function improved in both group of patients, but in those who initially had an impaired kidney function, they actually had a larger increase, improvement in kidney function compared to those who initially had a normal kidney function. Adverse effects to the treatment were few. Of course, some patients had some reaction to having these subcutaneous injections, but no one stopped the treatment due to these reactions. In addition, some patients had symptoms due to fluctuations in plasma calcium levels during the initiation of treatment, but after treatment had been titrated, plasma calcium levels remained rather stable, and most patients did no longer have these symptoms. So overall, treatment with Yorvipath seems to address some of the issues in the treatment of hypoparathyroidism. They cause stable serum calcium levels. They cause decreased renal calcium excretion while improving health-related quality of life and improving kidney function. They cause an normalization of bone turnover, which also is associated with a decrease in bone mineral density. It has now been approved by EMA and FDA, as well as other health authorities, including in the UK. It is injected under the skin, and 3 pens are used for the treatment, which have different strains: a low dose pen, a mid dose pen, and a high dose pen, providing these doses per injection. Most the dosing range accepted is 6 to 60 microgram per day. In most patients, they do well with one injection, providing up to 30 microgram per dose. A few patients, they need a higher dose, so they will need 2 injections, which are provided simultaneously, one after the other, thereby providing a dose between 30 to 60 microgram per day. In the updated guideline, there'll be a flow chart, and the flow chart have not been fully finalized yet. It's still a draft, so it may change from what I'm able to show you today. But the general principle for the for the for the flow chart is that if you have a patient with hypoparathyroidism, you should start to consider if this patient have reached the primary targets, meaning that this patient have no symptoms of hypocalcemia and have acceptable plasma calcium levels. If you have to answer no to this question, then you have to adjust calcium levels by adjusting dose of activated vitamin D or calcium supplements. If the patients have low plasma magnesium levels, you have to provide magnesium supplements. And if vitamin D status is below 70 nanomole per liter, you should add a supplement with native vitamin D. And then you should re-evaluate the patient, and hopefully you will be able to answer yes to the question that the primary target have been reached. After reaching the primary target, you should look for secondary targets. Does the patient have hypercalciuria, hyperphosphatemia, low magnesium levels, a sufficient vitamin D status, and stable kidney function? Once again, if you answer no, that you have not reached these secondary targets, then you have to adjust the treatment. If the patients have hypercalciuria, you may try to reduce the dose of calcium supplements and/or active vitamin D. You may try to reduce intake of sodium, as sodium is known to increase renal calcium excretion, or you may add treatment with a thiazide diuretics. If the patients have high plasma phosphate levels, you may try to adjust the diet, uh, recommending a diet with low phosphate in the diet. If there is low magnesium levels or low vitamin D status, magnesium or vitamin D supplements should of course be recommended. And then re-evaluate the patient, and hopefully you'll be able to answer yes to the question on secondary targets. When these have been reached, then you should monitor the patients every 3 to 6 months for signs and symptoms of hypo or hypercalcemia, quality of life, and measure plasma calcium levels, phosphate, magnesium, creatinine. once a year or every second year, it may be relevant to measure 24-hour urinary calcium excretion to see if the patients have hypercalciuria. It is reasonable to measure PTH level once in a while in order to find out if the patients have recovered their parathyroid function. And of course, vitamin D status should be adequate. And it's also of relevance to monitor comorbidities, symptoms of comorbidity, as I previously mentioned. We do not recommend renal imaging on a regular basis, but if there is a decline in renal function or signs of kidney stones, you should, of course, perform renal imaging. And we recommend DEXA scans of the bone as in the general population. In some patients, it is difficult to reach these targets. And if that a problem, then you should consider PTH therapy if the targets cannot be reached despite multiple optimizations attempts. And as I previously told you, PTH can be considered if patients have frequent fluctuations in their calcium levels or symptomatic hypocalcemia, impaired quality of life, reduced kidney function, persistent hypercalciuria, or high plasma phosphate levels. Then we suggest that PTH treatment with pyrrolobacter should be considered. And I believe that's what I have planned to tell you. So thank you very much for your attention, and please feel free to ask questions.
Thank you very much, Professor Rejnmark, for your fantastic presentation on the hypoparathyroidism. I think new things are coming around, so we should keep our eye open for them.